Hello everyone, I am Dr. Rohit Solanki. Today we are going to discuss one very interesting topic, oligodendroglioma. So oligodendroglioma come under the tumor classification of non-astrocytic glial neoplasm. Non-astrocytic glial neoplasm has total three number of main tumors under it. First one is oligodendroglioma, one is ependymal tumor, and another one is choroid plexus tumor. So, oligodendroglioma, today we are more interested in learning the oligodendroglioma. Oligodendroglioma arising from the oligodendrocytes. First, what is oligodendrocyte? Oligodendrocytes are normal neuron tissues whose main function is to maintain and to form the myelin. So function of the oligodendrocyte is to production and maintenance of the myelin. However, oligodendrocytes resemble the tumor called as oligodendroglioma. This oligodendroglioma is the third most common glial tumor in our body. So here is the location. Most common oligodendroglioma arise from the gray-white matter junction. Here in this image we can see that this is our gray matter and the white is the white matter. So somewhere here in the gray white matter junction this tumor will arise. In this photo of the MRI, here we can see that the hyperintense ill-defined lesion which is appearing heterogeneous hyperintense present somewhere at the gray white matter junction. So most common location of this tumor of the oligodendroglioma is supratentorial. In supratentorial condition, it's mostly 85 to 90% cases, while the infratentorial there is rarely 5 to 8% cases, which are more commonly in the children. In supratentorial, 50 to 60% or the most of the cases present in the frontal lobe, very rare in the parietal, temporal, occipital lobe. So simply, we can see that this is the most common oligodendroglioma arising from the gray-white matter junction. First thing. Second thing, it is most commonly in the supratentorial location. And third thing is most commonly in supratentorial location is the frontal lobe. So this is arising from the glial progenitor cells. Glial progenitor cells undergoes one mutation called as IDH mutation. This IDH is isocitrate dehydrogenase which help in the citric acid cycle. So this mutation then leads to the co-deletion of chromosome 1p and 19q. So this is successive mutation occurs which leads to the oligodendroglioma. Then after the mutations, it condition converted into the anaplastic oligodendroglioma. So this is the glial progenitor cell which leads to the IDH mutation. Then co-deletion of chromosome 1p 19q leads to the oligodendroglioma, and then successive mutations will lead to the anaplastic oligodendroglioma. So here we can see the IDH mutation, 1p19q correlation which leads to the oligodendroglioma. The same cycle is for the secondary GBM or anaplastic astrocytoma also follows. So gross pathology per se, we already discussed that this is the solid fleshy cortical based mass which poorly circumscribed blending into the adjacent structure. Here we can see that. Also here we can see that the blurring of the gray matter white matter differentiation with expanding one or the more of the gyri. So this is the ill-defined mass presenting as gray-white matter junction with expansion of the gyri. Here also we can see that there is a plier involvement with the calvarial expansion. So blurring of the gray-white matter boundaries with expanding one or more of the gyrus. Extension to the plial surface is common for the tumor, and cystic calcification and hemorrhagic conditions are common. So more or less we can see that this is a very ill-defined tumor of the which is touching to the glial surface and occurring mainly in the gray white matter junction. Also leads to the expansion of the one or two adjacent gyri, and also calcification, cystic and hemorrhagic changes are common in this tumor. So microscopic per se, it's a very beautiful egg, fried in egg appearance with compact close tissues with the microvasculatures present in between appears like the chicken wire appearance. So fried egg with the chicken wire appearance will be the classical symptom or the features of the microscopic in the oligodendroglioma. So imaging per se, the CT scan, so here we can see that this is a CT scan. So ill-defined margins with the focal or nodular area of the calcifications present with which is just touching the plial surface and leads to the expansion of the calvaria. So this is a peripheral cortical based tumor, most commonly occurs at the gray-white middle junction. Focal gyral expansion and thinning and remodeling of the calvaria is common. So on CT scan, we can see that the mixed type of the densities. Two-thirds of the patient will lead to the hypodense, while the 33% or the one-third of the patient with the mixed density because of the hemorrhages or the cystic changes or the calcification. 70 to 80% of the cases there will be calcification which have the clumped and nodule. Here we can see that clump nodule type of calcification present within the lesion. Here also we can see that there is a ill-defined cortical subcortical mass lesion covering the gray white metal junction, which has the focal or nodular type of the calcification appearing heterogeneously hyperdense to hypodense. Here also the same oligodendroglioma appearing in the frontal lobe. So, cystic and peritumoral edemas are common, moderate to heterogeneous enhancement of the post-contrast study. Sometimes it do not give enhancement. This depends on the consistency of the tissues in the particular lesion. So, on MRI, it scores the hypointense on T1 and hyperintense or heterogeneous hyperintense on T2 and flare. Because of the hemorrhages and the calcification, it shows the blooming on the GRE, and post-contrast either it do not shows the enhancement or shows the mild to moderate heterogeneous enhancement. On DWI, no restriction because the tissue are not so much compact, so do not show the restriction. This is 31-year-old female came with, this is the photos from the Osborne, came with the single episode of the seizure. Here we can see that the beautiful way-shaped hypodense lesion present in the frontal lobe on the right side. On the flare imaging also we can see that the homogeneous hyperintensity of this lesion shows in the frontal lobe with the expansion of the gyri spaces. On the T1 weighted T2 weighted image here we can see that the hyperintensity present in the frontal lobe. On post contrast study we will not show the significant enhancement. So this is a very shaped mass present on the CT scan. The 31-year-old female in frontal lobe expansion of the gyri. On the flare imaging shows the hyperintense. On T2 weighted image it shows the heterogeneous hyperintense and do not show the significant enhancement. This is our later comes to the WHO grade 2 oligodendroglioma. Next, a 31-year-old female came with the history of this multiple seizure attack. This here we can see that hypodense lesion present in the right sided frontal lobe with the nodule and the chunky calcification present within the lesions, which is mainly present in the cortical gray white matter junction, which is also leads to the bowing of the falx and the mass effect in the form of the ventricle collapse of the right lateral ventricle. Also show the existence of edematous changes. Later on the T2 weighted image here we can see that there is a heterogeneous hyperintense mass lesion with the fluid of beautiful hyperintense present within the lesion with the cystic and the calcification foci within it present in the cortical surface. On post-contrast study, we can see that the peripheral rim of the calcification is here with the focal heterogeneous areas of the enhancement. So peripheral enhancement is the focal area of enhancement. Mass is causing the mass significant mass effect. So later on, this is diagnosed as the WHO grade 3 oligodendroglioma. So this is 37 years old female came with the history of the repetitive seizure attacks and headache. Here on the parietal lobe we saw the one hypodense ill-defined mass lesion with focal nodular calcification within it, with showing the mass effect and involving the gray white matter at the cortical surface. On MRI also we can see that the hypo to heterogeneous high hyperintense mass lesion present in the parietal lobe. T2 weighted image shows the heterogeneous hyperintensity with the focal hypointense areas within the lesions showing the cystic, degenerative and the calcification foci. On post contrast study or post galvanum study it is showing the heterogeneous enhancement. Later on comes to the WHO class 3 oligodendroglioma. So this is a 24-year-old female come with the mass lesion hypoidence cortical based mass lesion involving the gray white matter present in the right sorry left side parietal, which later on MRI appearing the hypo intense on titulated image we can see there's heterogeneous hyperintensities will be there, and post contrast give the mild very mild enhancement. Later on come on pathology as a WHO class 3 or grade 3 oligodendroglioma. So this is all about the oligodendroglioma. In brief, we can see that it is a 60% or one-third cases present 230 cases present in the supratental location is most common in near to the frontal lobe, involving the gray white and the white metal junction, leads to the touching or the involvement of the plial surface, and also leads to the expansion of the calvaria, expansion of the particular existing guidance species. On post-contrast study, it will show the mild to moderate enhancement. It could land up in both WHO 2 or 3, depends on the characteristic of the particular lesion. Thank you so much for watching this video. I am Dr. Rohit. Kindly like.